Good afternoon. My name is Mark Siegler, and I'm delighted to introduce today's lecture, sponsored by the Bucksbaum Institute. The Bucksbaum Institute was created in September 2011 with a gift from Matthew and Kay Bucksbaum. The slide that I show you here lists the missions of the Bucksbaum Institute. They're pretty straightforward. To improve patient care, to strengthen the doctor-patient relationship, and to improve communication and decision-making between patients and physicians. We try to achieve these goals through research and education programs for medical students, junior faculty, and master clinicians. Today, it is my great pleasure to introduce our guest, Dr. Beth Lown. Dr. Lown is an associate professor of medicine at Harvard University and is the medical director of the Schwartz Center for Compassionate Care at the Massachusetts General Hospital. Dr. Lown has received many awards for outstanding clinical care and for medical education research. Dr. Lown's research focuses on many things, but it includes healthcare communication. Dr. Lown has developed innovative methods for bringing patients and physicians together to construct best communication practices in many different clinical settings. In Dr. Lown's current role as director of the Schwartz Center, she's responsible for developing and expanding educational programs nationally and internationally. Let me tell you just a bit about the Schwartz Center for Compassionate Healthcare. I know Dr. Lown will tell us many of the details, but the center's overall mission is to promote compassionate care so that patients and caregivers relate to one another in a way that provides hope to the patient, support for caregivers, and improves the healing process. Today, Dr. Lown will, and you can see the overlap and the similarities to the Bucksbaum mission from my description of the goals and mission of the Schwartz Center. Today, Dr. Lown will speak to us on the topic, what does it take to be compassionate in today's healthcare environment?
Well, I'm really happy to be here tonight, and I wanted to thank Dr. Siegler and Matt Sorrentino for inviting me to come. And really, my heartfelt thanks go out to the Bucksbaum family for their enduring commitment to compassion and communication in healthcare. I also want to note Matthew Bucksbaum's recent passing in November 24th, and I'm sure he'll be sorely missed. I wanted to convey my condolences to his family. And actually, I thought I might dedicate my talk tonight to celebrate his generosity and his commitment. So I'd like to begin my talk today by telling you a story. And you'll hear a lot of stories tonight. Storytelling is good. And I hope you'll talk with me, too. So I want to tell a story about this gentle man who became ill with persistent cough, fever, fatigue, malaise, just wasn't getting better, went in to see his primary care doc, couldn't get an appointment, saw another member of the team, and was given a course of antibiotics for what was presumed to be an atypical pneumonia. Several visits back and forth later, still unable to connect with his doctor. He was feeling very unwell, but more importantly, he was feeling very uncared for. Made the decision to switch doctors, switch institutions, and 3 months after the onset of his symptoms, he was diagnosed with non-small cell lung cancer. The year was 1994, and the patient was Kenneth Schwartz. Now, when Ken went in for his initial lung biopsies, the nurse who was doing his intake screening was harried, she was brusque, the waiting room was crazy, chaotic, crowded, and she wasn't paying any particular attention to him until he happened to mention that he had just learned he had advanced lung cancer. And the nurse heard something in his voice. She stopped, she looked up, she must have seen the fear and the sadness in his eyes. And she said, "How are you doing?" The next day, as Ken was waiting in the pre-op area to be rolled into the operating room for these biopsies, that nurse came down and looked for him, found him, sat next to him, held his hand, and wished him well. Ken wrote about his experiences in an article that was published in the Boston Globe magazine in July of 1995. And about this brief encounter, he said, "This small gesture was powerful. My apprehension gave way to a much-needed moment of calm. I realized that in a high-volume setting, the high-pressure atmosphere tends to stifle a caregiver's inherent compassion and humanity. But the briefest pause in the frenetic pace can bring out the best in a caregiver and do much for a terrified patient." Ken's family and his oncology team sustained him through periods of despair. From his doctor, of course, he needed clinical expertise, but he also needed compassion and hope not for some miracle cure, but for the certainty that his physician would provide the best available care as long as his quality of life was acceptable. And hope that he would have an expert clinical team of nurses, doctors, and other caregivers who cared not just about his clinical condition, but about him as a person. Ken unfortunately died 10 months after his initial diagnosis. And in the end, he said that what mattered most to him was the compassionate care he had received, that in his words made the unbearable bearable. Days before Ken passed away, he charged his family and friends with establishing the Schwartz Center, which was then established about a year after his death. And I'll tell more about the Schwartz Center in tomorrow's talk. So it gives me enormous joy to know that here in Chicago, another center has arisen based on the strength of the relationship between a caregiver and his patients. And I learned a little bit about Mark's style of caring. I especially liked the story about you appearing in scrubs in the OR when Matthew Bucksbaum was also having a lung biopsy. And when what was found turned out to be non-malignant, Dr. Siegler led the OR team in a spontaneous burst of applause. Such was the strength of his connection with this patient. Our origins are really similar, and the words of our founders are also quite similar. If you just listen to Kay Bucksbaum's words about you, it was just as much about compassion and communication as clinical competence, so much like what Ken Schwartz was also talking about. So let me ask each of you, how many of you really think this kind of care is important? Just raise your hand if you do. We actually asked this question of a nationally representative sample of 800 recently hospitalized patients and 510 physicians. We published our results in Health Affairs a couple of years ago, and we found that physicians and patients alike thought that effective communication, strong relationships, and emotional support are extremely important in medical care. So much so that it can actually make a difference in whether or not a patient lives or dies. And then we asked, does the US healthcare system provide compassionate care? And I want to know how many people would say yes to this question. Does the US, no one? Okay, we have some dissenters, okay. All right, so here's what we found. We found that half of the patients said no, and 42% of physicians said no, the US healthcare system is not providing compassionate care. And then we said, do most healthcare professionals provide compassionate care? How many people would say yes? Don't be afraid. How many people would say no? Okay, in our sample, 46% of patients, but only 22% of physicians said no. So we have a VQ mismatch. We have a disconnect between what patients feel they're receiving and what physicians at least feel that they are providing. Now, it's pretty hard to think about changing the entire healthcare system, but as Harvey Feinberg said at a meeting we convened to launch our National Consensus Project on Compassionate Healthcare last year, Dr. Sorrentino was there. Harvey Feinberg said, a compassionate healthcare system begins with compassionate people. And guess what? We are the system. So we need to think about what we can do to provide compassionate care, to strengthen it, and to help others provide it as well. So here are my goals for the rest of this talk. I am going to try to respond to these questions that I get all the time. What is compassion? What factors influence whether we'll respond with compassion or avoidance? And how can we nurture it and sustain compassion in today's healthcare environment? So let's go. To be compassionate, you kind of have to notice that someone's in distress. And this crayon picture by a 7-year-old girl kind of says it all. Here she is, she's sitting on the exam table. Her mom's holding her little baby sister, and her older sister's there reading a book. And there in the corner, pecking away at his computer, is her beloved pediatrician. Now, I don't know about you, but I have a lot of people who tell me that they're spending an awful lot of time fighting with a computer or with insurance companies or trying to deal with systems, and it's really hampering their ability to truly focus on the patient. But when we do, when we are able to really focus our full attention on the patient, it initiates a sense of connection that all by itself can be healing, and not just for the patient, but for us too, because it reminds us why we went into medicine, and it reinforces our sense of ourselves as healers. But it is not so simple. And especially in this day and age where we're all multitasking and we have all of these devices and pagers and beepers and the electronic medical record. So it takes a conscious effort to really focus your attention. And I use something I call the doorknob strategy, which I've also taught to some of my friends and my practice partners. So before I walk into an exam room or a hospital room, I put my hand on a doorknob or whatever I can. And I consciously set aside everything that's in my mind. All of that chatter, the tasks, the to-do list, just set it aside so that when I walk through that door, I can actually fully receive the patient on the other side of the threshold. And then our neural circuits start to get activated. They start to resonate. This is an automatic bottom-up phenomenon. It happens in anterior insular and cingulate cortex. It's called experience sharing or affective empathy by some people. And then within milliseconds, if we are watching a patient in distress or in pain, within milliseconds, other parts of the cortex start to jump in and get active. They start to resonate. We start to resonate with the experience of pain. We literally feel other people's pains in our brains. This is called mentalizing, cognitive empathy. It's perspective taking. And our responses to this neural activity in our brains is modulated by factors that have to do with the patient, with us, and within the larger context within which we are seeing that patient and witnessing that patient's pain or distress. So what happens when the cultures, the time pressure, the volume pressure, the cultures of care that we are working in, organizational climate, whatever you want to call it, some people call this the hidden curriculum. What happens when it literally blinds us to the experience of the patient? So this is an amazing painting called 8.5 Medical Students by Métis Boigna-Pradis. It was published a couple of years ago. So what is she saying here? What is she showing us in this picture? Speak out so I can have a conversation with you. What do you see? What is she trying to say here? Yeah. Exactly right.
They're standing there, but are they really there?
Exactly right. They're blindfolded. They can't see that whole person in that bed, half of which is imagining himself at home with his kids in the background, right? They can't see the patient in the bed, and guess what? They can't see each other either, and they can't see themselves. So this reminds me a little bit of an experience I had some years ago when I was rounding on a patient with sickle cell crisis, and I was demonstrating the exam of the knee and so forth. We left the room, and I said to one of the physicians, "How are you managing his pain?" And he said to me, "Oh, they're all just drug seekers." So this was just one person's response to this man's predicament. But there's so much research that has shown that in just the kind of conditions that we practice in all the time pressure, volume, clinical complexity, clinical uncertainty, we start to activate assumptions and bias that not only lead to the suspension of compassion, but they lead to medical errors in diagnosis and to disparities in care. To experience compassion within ourselves and to really provide compassionate care, we have to care about the patient. We have to value the patient's welfare. When all of these are aligned, we focus our attention, our activated circuits are buzzing and resonating in our brains, bottom up, top down circuits. We perceive the need and we value another person's welfare, then we experience compassion within ourselves. And this is the research definition of compassion: other-oriented emotions elicited by perceiving another's distress, coupled with altruistic motivation and action to ameliorate that distress. And then there blooms this family of compassion-related emotions: tenderness, kindness, a kind of professional love, caring, concern, sorrow, and even grief at the suffering person's plight. So let's take off our blinders. And let me show you a couple of pieces of this jigsaw puzzle. So let's hone our clinical skills. I'm only going to show you a teeny little piece of this puzzle. But what do you see here? This is a patient in some side of a hospital bed. What clues do you see here? Anything? How about at the bedside nightstand? Any clues about who this person is in this bed? Now, what do you see? What do you see down there? If you can see this part here. Clues about who this person might be or his circumstances.
The resolution on the photo is really bad. The big screen, I think that's what it is.
Try looking at the littler ones are a little clearer if you can see it. Can you see the little screens better? So what do you see? Yeah, there's a bottle of Sprite. Anything personal on the nightstand there? Huh? Not really. No pictures, no photos, nothing personal there. Well, that's a clue, isn't it? Okay, and then what about this little piece of arm? Look up at the smaller screens. What can you say about this guy's clinical state, just looking at his arm? Huh? Let me come up and hear you. His watch doesn't fit. Why not? He's lost weight. This looks like a cachectic arm, doesn't it? Yeah. Okay, but what about the watch? It's like not a bad watch. So maybe he was a person of means at one point, but something's happened to him. He's lost an awful lot of weight. It's kind of cachectic. You can see his veins sticking out. So is it important to know this kind of stuff? Who does this man call his family? Who are his sources of support? What about his culture, his heritage, his current circumstances? We see the rumpled bed sheets, but who is this person in the bed? Is that important? Should we be asking the Kleinman questions? Have you guys ever read this incredible paper by Arthur Kleinman called Culture, Illness, and Care? It's a classic. Do you get this in medical school? Arthur Kleinman is an anthropologist, a physician, a medical anthropologist. And he talked about the patient's explanatory model, how the patient makes sense out of what's happening to him or her. And we actually do teach our medical students these 8 questions that we think are important. I'll just summarize them. I don't know them by memory, but they sound kind of like this. What do you call your illness? How does it work inside your body, just so I can create my own mental picture of what you think might be going on? What kind of treatment have you tried already? What kind of treatment do you think you should have? What are your expectations for treatment? What are your major concerns or fears about this illness? There are 8 questions. That's just a few of them. Is it important to know this? Is it important to know this? This homeless man was found living in his car with his dog in a Walmart parking lot until he was discovered unconscious by EMTs and brought to the hospital. Is that important? Is it our purview to understand these pieces of information about a patient, or is this something that just social workers and case managers should be doing? Is this part of our role and our responsibility? How can we come to know the answers to these questions, and how can we provide compassionate care if we don't? Eric Cassell described suffering as the state of extreme distress associated with events that threaten the intactness of the person in any of multiple domains: physical, social, emotional, psychological, spiritual. These are such important aspects of who the patient is as a person. But perhaps I think most importantly is this question: who does the patient love? Isn't this the most important question when all is said and done? To be able to say that we have loved and been loved in return? Hospice workers arranged for the reunion between this man and his dog, which was really the only thing he wanted before he died. And they described the experience of watching the dog find his way through the hospice unguided and leap onto this man's bed and literally pour her body over the body of this man until it was time for him to go. We straddle a really unique set of worlds in this profession of ours as caregivers. We straddle the world of medicine and the life worlds of our patient. And they invite us into their worlds all the time if we care to listen to them. But most of the time we miss their cues and clues because often patients don't talk about themselves directly. They don't express their concerns directly. So you have to be listening for these cues and clues. I've been interested in communication and relational skills for many, many years, and I've listened to thousands of audios, watched thousands of videotapes of doctor-patient communication. And what I've seen and heard is that physicians especially are following this line of reasoning inside their heads towards a differential diagnosis. And so focused are we on that goal that we tend to literally not hear or hear and avoid, interrupt, or redirect patients' expressions about who they are and what they're concerned about. But we can do differently. We can learn how to listen, and we can learn how to respond. So what I'd like to do is show you a very, very brief video clip. This is a great teaching resource, by the way. This is called OncoTalk. It's free on the web. It was made by 3 colleagues and friends of mine, Tony Back, Jim Tulsky, Bob Arnold, to help oncologists communicate more effectively with their patients. So in this video I'm going to show you, Jim Tulsky is working with a simulated patient, and he's telling her some really bad news. How many of you have had to share really bad news with a patient? So I want you for a second just to put you in that mindset of what that feels like. You're going to go into somebody's room and you know you have to do this. So just imagine for a second what that feels like. And then watch Jim Tulsky, and at the end I'm going to ask you what you saw. Okay?
So when the scan showed some things we weren't expecting, it actually showed that the cancer has come back in your liver and your lungs.
I see. Well,
I know this is a lot. I know it just sort of dropped a bombshell.
this is not what I was expecting.
It wasn't what I was expecting either.
And so, does this mean?
It means we have to look into this a little bit more. Some more tests, and we'll talk about some more treatment. We'll do this together.
Does this mean I'm gonna die?
I know it's really scary. Not knowing what's going to happen.
Alright. I don't know what to think.
Of course you don't. There's a lot going on. We're going to take this together. We're going to do this step by step. And we're going to face whatever comes.
Okay. What do we do next?
We have to talk a little bit about treatment and what the different options are.
What did he do? What did you see? Can you name any of the skills that you saw him demonstrating? Yes, please.
He used the word we. He was talking to the patient, and that just made it seem like it's her issue, her problem. He believed himself as part of like they're going to do it together, like a team came for encouragement.
Absolutely. We, that's called partnership. Yes.
He acknowledged and approved of her emotions.
He acknowledged her emotions. He validated, legitimated her emotions. Didn't try to squirrel them away.
What I was going to say is he gave her an opportunity to express them. He was quiet and allowed her to talk.
Yeah, silence is powerful, isn't it? Silence with presence, unbelievable. What else? Other things. I saw some more hands up. Any others? There's a few more things there. So there's always room to do things a little bit differently. Anything else?
I just say he didn't reach out or,
Touch her. There's a little bit of distance. All right. Yeah? Yeah. Sometimes it's helpful. Sometimes it's helpful, and sometimes it can sort of send a message, okay, that's enough, let's stop crying now, dry your eyes and let's get on with it. It's a tricky thing. You have to be super careful because it can signify the end of that expression. Go ahead.
I'm not sure what normally has to happen when you give someone hard news, but it seemed like she was alone and there was no family there. So in a sense, like him saying, like, we'll do this together, it was partnership, but I wonder, like, maybe she would have wanted someone else.
Yeah, where's the rest of the team? Yeah, the family team. Okay, fantastic comments, yeah. Yeah, well, we don't know, of course, because if it's just sort of a little snippet. But it is true that going to one assumption is not always the greatest idea. You really need to explore what the possible options are and see where the patient is at. How are you feeling? And sometimes the best thing after you give somebody a piece of news like this is just to revisit it, unless the patient really wants to, because they're not going to hear anything you're going to say, you know. Yeah.
No, that's what I noticed. I thought it was really great how he didn't, like, when she asked what are we going to do next, he didn't say, well, we have to do this test and this test.
Yeah.
And he kept it very broad because I'm sure she wasn't going to.
She's not going to retain it. Exactly right.
Really
Yeah. Last one.
I also think he didn't make any promises that he couldn't keep. Like when she asked if she was going to die, he didn't say absolutely not. Like he was, I mean, he obviously like acknowledged the fact that she was scared, but he didn't like take the step and say, no, that's definitely no way. That's
Not happening. Not happening. Yes, because after all, aren't we all going to die at some point in time, right? Yes.
But I thought the way you commented gave her hope.
Yes. Yes, hope. Hope is so important. Yes, yes, of course, of course. These are great comments. Oh, I should have brought more videotapes. Okay, we're going to move on. It's being, I call this the RSVP skills, to remind us to respond to patients' emotions, to RSVP to them. So there are a couple in this little toolbox, and it's not to script what you're going to say, but it's to help you remind yourself what might be useful when you're feeling kind of, nervous, under the gun, tense, anxious, and having to respond in the moment. So one is reflection. This is an incredibly powerful skill, especially in motivational interviewing, which is a topic for another day, but you track what people are saying so incredibly intently that you can capture the essence of it and reflect it back to them like a mirror. You don't ask questions. What happens? Who's in control of the conversation when you ask a question? What do the rules of conversation dictate? I ask you a question, you have to follow my agenda and respond to my question. Reflection of voices, it lets the person sink deeper into what they're thinking and feeling, and then they can share it with you. Respect for the patient's efforts, persistence, braveness, whatever. Support, I'm here, I'll be here. Validate. Of course, it's completely understandable that you wouldn't know what to say. I just hit you with a bombshell. And then the word we, using expressions of partnership. We'll be in this together. Then we can get going into this process of compassionate discernment, which is really about trying to understand what the patient needs and wants and what you can offer. I want to show you an example of this last bullet of co-creating a pathway forward that represents the integration of our clinical expertise, our sense of what's ethically appropriate, and the patient's fears, concerns, and preferences. So to do this, I'm going to read you a story. And this is Sandra's story. I met Sandra many years ago, and she had an autoimmune disorder that affected many organs, and especially her lungs, and she wound up being hospitalized, intubated, in the ICU, on a ventilator, 6 times over 8 months, and she had just had it by the end of that time. She was young, she was probably only in her 30s at that time, but she prepared her advance directive so that the next time this happened, she wouldn't be in an emergency room unable to express her wishes. Sure enough, it happens again. She drifts into respiratory insufficiency, she winds up in the emergency room, and she hands them her advance directives and says, I don't want to be intubated, just make me comfortable. The ED staff goes nuts. Everybody's flocking around trying to convince her to be intubated. You're young, we can save you. But she was firm. Until she met this one man, a critical care doctor. She had never met him before, came down to do the consultation, and instead of trying to persuade her why she should be intubated, he said, tell me what you cannot face. What could we do differently? So now I'm going to read you the rest of her story. What is it you can't face? Tell me what we could do differently. The restraints, I feel like an animal. They tell me I have to be restrained because I'm agitated, but I'm trying to get free. He assured me he would not allow me to be restrained. He told me he would stay with me until I was stable and calm. If he had to leave, he'd leave explicit orders to call him if I became restless. No one would have permission to restrain me. And the morphine, I don't want to be doped up all the time. I need to be able to ask for it when I need it. Sometimes it's more important for me to be alert so I don't slip away into the rhythm of that machine, breathing in and out, in and out. He showed me the order sheet as he wrote a PRN order for morphine. Our conversation couldn't have taken more than 5 or 6 minutes, but it was a powerful force. I could feel myself slipping into the dreaminess that would end my life if I refused the ventilator. Literally, this man stood between me and death. He took my hands, looked at me, and said, I don't want you to die. In a few minutes, you'll be unconscious, but I won't do this if you say no. We can work together on this. Those words conquered my fear, the fear of having no control in my life. He was willing to make my wishes primary. In that moment, he returned my humanity to me. I nodded agreement. He did keep his part of the bargain to honor the things I didn't want, and made the next few days easier to endure. This time, the ventilator didn't possess me. It was different, because I was able to say no. No to restraints, I could reach the call button. No to scheduled morphine, I could decide if it was more important to have relief from pain or to be more conscious. No to isolation, I had a paper and pencil and could communicate. I had choices, and I was able to make decisions about important aspects of my care. This brief dialogue pulled me back from the only decision I thought I had left to make. One human soul reaching out to another made space between 2 extreme options. Either yes, agreeing to everything the doctor ordered, or the final no. Sandra went into remission. She survived. She told me this story several decades later. It's an amazing story, and there's an awful lot to talk about it. One of the things, of course, that I'm always amazed by, that always strikes me, is how together these two people really did co-create a pathway forward that neither one of them could possibly have imagined on their own. And they went into that very gray territory where there's no decision aid that's going to tell you the right thing to do. The only thing they could do was connect with each other and try and discern the way forward. It's a powerful story. So having heard this story, thinking about the compassionate caregivers you've seen, compassionate clinicians, what would you say are some of the characteristics of compassionate caregivers? What characterizes them? Thinking about this and about people you've known, your mentors. What are some of these characteristics? Yes?
They respect the dignity of the person, and so they really try to do what that person wants.
Yes.
And like also address them in the way they want to be addressed.
So they listen, they respect the preferences of the patient, they try to understand what their needs and wants are. What else? Some other characteristics. What does it take? Yeah.
Listen to their stories and ask them questions that affect their day-to-day life. Not just focus on like the situation at hand and things that can affect the situation like outside of the box.
Yeah, they try to understand the larger context of that patient's real world. Yeah. Way up in the back.
They're fully present.
Fully present.
Fully present
And
and self-compassionate.
self-compassionate. Ah, what do you mean by that?
Well, I think to provide compassion to another, you have to have great love and compassion for yourself.
What a wonderful comment. Thank you. I'm going to get back to that in a moment. Here are some other characteristics that we thought of at our meeting last year. Open, non-judgmental, interested, respectful, empathetic, attentive, present, unconditional kindness. I love that. Caring, concerned, they're listeners, they're communicators, and they have a collaborative spirit. They're self-aware and reflective. I'm also asked this question a lot. What distinguishes compassion from empathy and sympathy? And this is a diagram from Mohammad Reza Hojat's book on empathy. And he talks about empathy as really being higher up in the cognitive side, perspective taking. It's feeling with another, imagining yourself in someone else's shoes. Sympathy is feeling sorry for someone. Sometimes it can have a little bit of a hierarchical flavor to it. And there right in the middle is compassion, and that balance point between cognition and emotion, and it's feeling for another and action. You can be empathic but not act, but it's not the definition of compassion. Compassion implies action to transform suffering. This is the empathy-altruism hypothesis, C.D. Batson's work, very, very brilliant social psychologist and researcher, and he says that compassion, as we defined it earlier on, leads to this state, empathy-induced altruism, in which the ultimate goal is increasing another person's welfare, not our own. That's really the foundation of professionalism too, isn't it? So we have this model that we're starting to create with compassion. And I'm going to show it linearly because that's how PowerPoint works, but it's not linear. It's all happening all at once, and every piece of it is influencing every other piece. It begins by focusing our attention being truly present, not multitasking. Then we activate these neural circuits in our brain if we're witnessing pain and distress. We perceive a need. That awakens empathic concern, and if we value the patient's welfare, then we experience this altruistic motivation and intention to help. We can go through that communicative process of compassionate discernment in order to take compassionate action. But the other point I want to make right here is that our ability to experience compassion and to offer it to others is totally integrated with our own sense of well-being. We cannot consistently provide compassion or even experience it if we ourselves are distressed and suffering. And I think that part of the problem is that often today, many of us are kind of feeling like this. We're really just holding on by our fingernails to the edge of the cliff here. I probably don't have to tell you all of these hazards, but I'm going to just list some. I know that physicians in particular are just notorious for our self-neglect. There's pathological altruism, where you give until you just kaboom, fall right down off the edge of that cliff because you haven't noticed any kind of warning signs that you're kind of reaching the end of your rope. There's burnout, and the statistics on burnout are really shocking. 30 to 60% of healthcare professionals experience burnout, which is emotional exhaustion, depersonalization, in other words, treating patients or viewing them as objects, and having a low sense of personal accomplishment. And here's another figure, which is really very upsetting. That completed suicide is just incredibly much more prominent and prevalent in physicians and in the general population, and especially for women. It is just amazing. This is work by Eva Schernhammer that she published in the New England Journal and also in the American Journal of Psychiatry. It's important work to take a look at. People who watch trauma all the time can experience trauma themselves, vicarious trauma, start having PTSD-type symptoms. There's moral distress when you know what the right thing is to do, but you can't do it because you can't speak up against the power hierarchy or because your values aren't the same as the organization you're working for. And then there's exposure to disrespectful behaviors, what some people call the hidden curriculum. All these are big problems, and what we're seeing is that personal distress is leading to the natural desire to reduce our distress, and then that we activate these defense mechanisms that are kind of understandable, avoidance and detachment. This is work by Jean Desetti here at the University of Chicago. Probably know all of this work. But his work shows that physicians actually downregulate empathy for pain, and I find this really intriguing. So if you show a control person, a normal person, not a physician, somebody who's being pricked by a pinprick or touched by a Q-tip, control people who are not experienced clinicians have significantly different evoked responses to that stimulus, those two stimuli. But if you show physicians the same thing, there's no significant difference between their responses to those two different stimuli. And the other interesting thing is that it happens both in that early bottom-up, you know, the anterior insula singular cortex, that automatic first process that we talked about. It happens early, not just in the late phase. So our whole hardwiring with increasing experience gets altered when we witness people's pain. We can't help it. This is important information. So what are we supposed to do? Are we supposed to be upregulating our empathy? Are we supposed to be downregulating empathy so we can survive in this world? What are we supposed to do, and what are we supposed to be teaching? And then, of course, there's the system with all of its impediments that contribute to burnout, workload, all of these new administrative and operational requirements, fragmentation of care, conflicting values, loss of sense of control and autonomy, and this painful sense of loss of community among colleagues, where people feel really, really isolated. So I think the key question, and it's a burning question, is what determines whether our observation of patients' distress is going to elicit compassion or if it's going to elicit avoidance, and what can we do about it? So in addition to our compassion being linked with our own sense of well-being, our existence is, it occurs, we all exist within these sort of nested concentric circles of cultures, microsystems that we live in all the time. Whether it's just individual relationships or whether we're working on a team or on a unit, we live inside these cultures, multiple kinds of cultures. And we can decide we're going to do something about being compassionate. We may not be able to change the entire US healthcare system, but we can think about ourselves and how we want to change ourselves and how we want to retain or change our responses to distress and suffering. And we can make change one conversation at a time. We can influence others in our microsystems of care. We can choose our own way. If you've never read Viktor Frankl, Man's Search for Meaning, you really have to read it. He was a psychiatrist. He's a concentration camp survivor. And he said, everything can be taken from a man but one thing, the last of the human freedoms, to choose one's attitude in a given set of circumstances, to choose one's own way. So we can decide what aspects of our witnessed experience we choose to attach meaning to. So let me ask you this question. Think for a moment about a time you've had, whether as a student or as a clinician, when you felt that what you were doing was highly meaningful and you felt happy and fulfilled. Can you think of such an experience in your past? Just take a moment to reflect on this. Think about what that was and what you were doing. Does anybody want to share an experience that they've had like this? It can be in your training, on the wards, at work, or not at all having to do necessarily with school. Anything? No brave souls? Okay, please go ahead. So when you really think about this, thank you so much for sharing that story. When you really think about it, and when I think about my own experiences, the times that have been most meaningful to me are these times when we felt connected with somebody, when we felt that we were really trying to assuage fear or anxiety or make their lives just a little bit better. But you know, that sense of purpose isn't something that just happens. This is Mihai Csikszentmihalyi. He writes a lot about creativity and flow. And he says, you know, happiness or a sense of purpose in life, it's not something that's just going to happen to you. You have to prepare for it. It has to be cultivated and defended. So some of this involves taking care of ourselves. As we said, you can't be compassionate to other people if you don't take care of yourself. You know how they say on an airplane, you're supposed to put the mask on yourself first before you put it on someone else? So these are some really common self-care strategies that people use to cope. And I have to tell you, I learned this in the most unhappy of circumstances. It was after the Boston Marathon. And a group from Israel, the Israeli Trauma Coalition, came to teach us this model of self-care strategies to help people cope with some of the trauma they were experiencing. It was a dreadful time. But take a look at all of these. They're so interesting, and they seem to be common strategies across cultures. Guess which ones physicians tend to use most? Just take a wild guess. It's cognition. Yes, we've done this experiment in several workshops. So beyond self-care, I think that there are educational curricula that we need to develop, that we need to learn for ourselves and we need to teach everyone else. So I'm going to show you my wish list. The first one is curricula on mindfulness and really trying to understand what it means to focus one's full attention. Balanced emotion regulation, so you don't fall off the cliff, you recognize warning signs. And there's so many different strategies. I've only listed 3. But there's lots of ways to manage one's own emotions and to survive without numbing. We have lots of communication skills courses in the United States. There's not a medical school that doesn't have them, that doesn't teach them, but it's usually in the first 2 years. And rarely in the 3rd, 4th clinical years and beyond are they deepened and advanced and made more complex or even modeled. And that is just, it drives me crazy. We certainly need better skills in complicated and essential communication skills. We need curriculum that puts into action, that teaches us the behavioral skills that activates awareness of cultural issues, literacy, socioeconomic issues. It's not enough to just know what they are, these issues. We have to then understand how to translate these into action and interactions with patients. We need relational skills, that kind of partnership that Sandra had with her doctor, which is really all about sharing control, sharing power. How willing are we really to do that? Can we really collaborate? Can we be flexible? And how well do we manage uncertainty? Our difficulty in managing uncertainty is really, I think, causing a lot of overspending on treatments and tests and things like that that may not be what patients want and may not be necessary. Meta-awareness, metacognition. We actually teach our medical education fellows how to be present in the moment. And at times, just taking little timeouts, going up onto the balcony, so to speak, to think about, well, what am I thinking? What am I feeling? What is that person thinking or feeling? And what's happening in this space between us? What's going on in the dynamic within this room or in this team? It's metacognition, meta-awareness. These are skills that you can practice, you can learn. We do it all the time. We teach it all the time. And we certainly need these skills for self-care and self-compassion. And so following up on your comment about self-compassion, I want to show you the definition of self-compassion that's been offered by Kristin Neff. She's a psychologist at UT Austin who's been working in this field for a couple of decades. And this is her definition of self-compassion: being touched by and open to one's own suffering, not avoiding or disconnecting from it, generating the desire to alleviate one's suffering and to heal oneself with kindness. It also involves offering non-judgmental understanding to one's pain, inadequacies, and failures, so that one's experience is seen as part of the larger human experience. How awesome would it be to be able to offer this to ourselves all the time? If you are interested, Google Kristin Neff, and she has a little self-compassion test that you can take right on her website. You can see what your score of self-compassion is. You may be surprised. I was surprised. So does this make any difference? How does this impact patients? I know a lot of people want to know about the linkage between empathy, compassion, and patient outcomes. And one part of me thinks, why do we have to prove this is important? How much evidence do you need to know that empathy and compassion is important? Why do we have to prove it? But I understand the reasons for it too. So this is work by Hojat. He developed the Jefferson Scale of Physician Empathy. I don't know if you have heard of it. And this is work correlating physicians' levels of empathy with patients' diabetic outcomes. And what he showed in this particular study was that patients of physicians with higher levels of this reported empathy were more likely to have better control of their diabetes and LDL cholesterol than patients of physicians with lower levels. And he's done more work. He's had another work published looking at literally thousands of patients with diabetes in Italy, showing similar results. Patients of physicians with higher levels on this scale, their patients with diabetes have lower rates of diabetic complications. So there is starting to be some early evidence about the correlations between empathy, compassion, and other kinds of outcomes. So let's go back now and start thinking about, okay, what are some of the strategies that we can teach ourselves while we're waiting for these educators to start developing curricula that we need? So this is one thing that I'd like to pick up on, and this really gets back to Viktor Frankl and Csikszentmihalyi's work about we can decide what kind of meaning we choose to attach to our given experiences. We can choose. And one of the ways of doing this is by using something called cognitive reframing. So let me just tell you a story about a patient I had who I took care of for a long time in my primary care practice, and I really loved this woman. She was just sweet and gentle, and at a time when most people are retiring, she and her husband were taking in one of their kids, one of their sons, who had had a terrible thing happen to him and a divorce, and she was wallpapering a room in her house for her little grandchild. And then she became very ill, and she had a very aggressive kind of a tumor. And she went through some terrible chemotherapy, a lot of chemotherapy, radiation, surgery, 2 craniotomies. And then when it came time to really think about what we could do, she chose to go home with hospice care. And I always went and saw my patients when they transitioned to hospice. So I'd make home visits to see her. She was on this huge hospital bed in the middle of her living room, surrounded by her many children. I think she had 6 kids, and all her grandchildren. Couldn't have been too peaceful, but she looked okay. And she said she was comfortable. And she had one daughter, the youngest daughter, who wanted everything done. She wanted that feeding tube. She kept telling her mother, don't give up, don't give up. She wanted the feeding tube. She wanted her to be a full cold, but her mom had been pretty clear while she could still be clear. And the mom passed away, and I was thinking about her, and then I got a call and a message that this young daughter wanted to come in and talk to me with her dad. She was incredibly angry at me. I should have diagnosed her mom earlier. I should have been much more aggressive earlier on in her care. I should have done so much more than I had done for whatever reason. And I was so taken aback. First of all, because I really loved this woman. I cared about her a lot. I thought I had done everything I could. So I started to get really upset. And then I started getting really anxious. And I started looking through her chart, second guessing myself. Was there anything I could have done differently? And then I started getting really angry at this woman. You know, I've given so much. How can you possibly come in and tell me that I didn't do enough? So I was kind of stewing on this a little bit. And then one afternoon, I was out of the office for whatever reason. One of my practice partners took a call from her. And he said later when I came back, you know, I think she really just wanted to be sure she had been a strong enough advocate for her mom. And that little throwaway comment just turned everything upside down on its head for me. And I thought, of course. She had never been able to really give herself up to the process of her mom's dying. She had never resolved anything in her relationship with her mother. And she certainly had never said goodbye. And once I could hold on to that perspective, I was really able to decide that the best thing I could do was just sit with her, to listen to her, to bear witness to her grief, which was being disguised as anger. And it helped me let go of my own anxiety and anger at her. And she decided to just go ahead and let it go and start to grieve. So it's an example, it's a powerful lesson to me of how helpful this kind of thing can be. Cognitive reframing, choosing what aspect of experience to focus on. There are many, many other strategies that we can use, and there's some really interesting kinds of curricula that are being developed. You may have heard about this curriculum by Ron Epstein and his colleagues up in Rochester. And a lot of people now are developing curricula in mindfulness and mindful communication. And this was an intense curriculum where people, 70 primary care docs volunteered to do this. And it was a pre-post study. It wasn't a randomized control. It wasn't even a quasi-experimental design. It was just pre-post people who wanted to do it. They had appreciative inquiry, narratives they would write and share. They would do some meditation, contemplative practice. And it was very intense. It was like 2.5 hours for 8 weeks, 2.5 hours a week for 8 weeks. Then there was a 7-hour retreat, and then there was a 10-month maintenance phase. And what he found was there were improvements in mindfulness and empathy and less burnout. And some of the aspects of mindfulness seem to correlate with one particular scale, the cognitive scale of the Jefferson Scale of Physician Empathy. So it's interesting and it's promising, and a lot of people are now starting to develop different kinds of curricula around this theme. There's this other educational intervention called Schwartz Center Rounds. How many of you have been to a Schwartz Center Rounds? Can I just see? Oh my gosh, you guys have to go. So Schwartz Center Rounds, here's how they started. After Ken died, his friends and family went to his care team and said, what do you guys need to make sure that compassion doesn't die in healthcare? And they said, we need a place to be with each other. We need a place to talk to each other, to really talk about what we're feeling, to process our experiences together in some kind of community. And so the Schwartz Center Rounds were born, and they're now in over 370 places across the country, and now they're spreading like crazy into England, and more about that later. So the Schwartz Center Rounds are a place where anyone who touches the care of a patient in a given organization, whether it's a hospital or community center or nursing home, can come together and talk about some of the social, emotional, psychological aspects of taking care of patients every day. They're very powerful, they're very moving, and we did evaluate them. And the interesting thing that we saw, aside for improvements in responses to different scales we had developed, and we used a modified version also of that Hojat scale, the Jefferson Scale of Physician Empathy, and we used a modified version of a burnout scale. But what we saw amongst the pre-post study, people who were, before they started attending the rounds and after they had attended 7 or more, after the site had been doing the rounds for 7 or more rounds, we found this dose response curve. It was so interesting that people who attended the rounds more frequently had more positive reactions in this scale we call the patient interaction scale. So 1 rounds is the little speckled stuff, and the dark stuff is having attended 6 or more, and the middle one is 2 to 5 rounds. So people were more likely to have increased insight into these aspects of care. They were more likely to focus on social and emotional aspects of patients' experiences, and they felt more compassionate. And we also saw an improvement in teamwork, perceived teamwork amongst people who attended the rounds. And finally, we saw an improvement in caregiver distress. So again, it wasn't a randomized control trial, but it's a suggestive study. So back to our model of what compassion really is. And here are all its little pieces completely integrated with our own sense of well-being and nested within these organizational cultures we all live and thrive in. I think that we can develop education, learning strategies, and research in every single aspect of this model. And when it comes down to the very end, compassion is good medicine. It heals people who are distressed and who are suffering. It reminds us why we chose to go into medicine in the first place, or nursing, or any other healthcare profession. It nurtures our sense of well-being, and nurtures the well-being of the people that we serve. And it creates a sense of meaning and purpose. It reminds us of our common humanity. So what does it take to be compassionate in today's healthcare environment? It takes commitment. It takes commitment to these points that we created during the meeting that we had last year. There are others, I'm sure, but these are the ones we focused on. It takes a commitment to compassionate leadership, education. It takes a commitment to value and reward compassion instead of amounts of procedures done, number of visits. It takes a commitment to support caregivers' well-being, to involve, educate, and to learn from patients and families. A commitment to build compassion into the very fabric of how we deliver care, to really put patients' needs at the center of how we design the processes of care, not just lip service about patient-centered care. And to deepen our understanding, to do more research into these realms. If you are interested, go on our website and read our full call to action. If you feel so inclined, endorse it. It doesn't require any money. And it also requires this commitment to self-care and self-compassion. I just love this quote by His Holiness the Dalai Lama. Love and compassion are necessities, they're not luxuries. Without it, humanity cannot survive. So you can choose your own way. You can choose to serve and to heal. You can choose to provide and to promote compassionate care. Each and every one of you sitting here can make a difference. You like the picture? So I'll end here, and I thank you for listening. Anybody want to ask questions? Or, really?
My question is, how do we reconcile when we are the reason why the patient is in distress? For example, when patients emergently need a procedure, when I am in the picture, the person is sticking the needle in the patient. How do you operationalize compassion and empathy in a moment when you know that there is a necessity for what you have to do, but at the same time be able to sort of operationalize compassion and empathy while also respecting the fact that the patient in that moment does need that intervention for their survival?
And the intervention might inflict pain?
Exactly.
Okay, so let me ask you to answer the question, then I'll say what I think. So what do you think? What do you do when you have to do something that might cause some distress, but you have to do it because the patient needs it to be done? What do you do? How do you sustain your compassion and how do you express it to others? Yes?
I'm going to be in stereo. So as a psychiatrist, a lot of what we do to help actually makes people feel worse initially. And I think that I'm ever mindful of the fact that part of being present and compassionate is accompanying someone in their pain. And so I think from everything from when you're sticking a needle, not racing out of the room because it's so hard when the person's in pain, to saying, I'm really sorry that hurt. Is there anything more I can do for you? To being honest about the fact that it's going to cause them pain, and to reminding them, which is what I try to do when someone is angry or crying or sad, that this pain actually has value because you're going to get better through the expression of it.
It's to help the people understand, help the patient understand about the fact that it's done with the intention to help, to be of help. But there's more, I'm sure. What else would you all say to this question about how you sustain compassion and express it in the middle of having to do something that might be painful.
Because I think the issue, you brought up the issue of upregulation and downregulation, and I think that in a career where you have to sustain yourself, and I think the self-care issue is hugely important.
Yes.
And I think that there are several bodies, professional societies, the ACGME, otherwise, who are really pushing the issue of fitness for duty and having house staff really assess their own fitness, but also recognizing that, you know, that upregulating and downregulating, that every day that you're going through, you know, every single time you are doing a procedure, every single time you're starting an IV, you're drawing blood, that you are going to be causing someone distress. And so how to reconcile that and be able to have a tolerable amount of distress of on your own, I think is the issue that sort of I question.
It's really, really, I think it's actually really hard in some ways. I'll express, does anybody else want to add? Please, go ahead.
So, I'm a pediatric ICU doctor, so I
there
guess I'm the key of who does this every day.
I knew there was wisdom in this room.
And I'm just thinking about to a little girl that yesterday I had to put a feeding tube in, and that was the last thing that this 4-year-old wanted done. And we started out by just sort of saying, oh, we went to the playroom today, and you know, you got to see a puppy dog, and you've got a puppy dog here, and what's their name? You know, I mean, so we tried to establish a relationship beyond, and then we explained what had to be done, and then we unfortunately held her down and did it. But we told her that she was really brave the whole time, and then this morning when we went in to see her, we even said, you were so brave yesterday for us to do this. And so I think it's just doing those little things of going the next, instead of just walking in and saying, okay, I'm going to do this, but really trying to establish a relationship, even if it's in an emergency room or even if it's in a situation that you've got to move relatively quickly. But if there's one or two, if you can spend 30 to 60 seconds of talking about something else and then try to explain what's going to happen as best you can.
So the key is to make some kind of a connection, even if it's a brief one in the beginning, to explain what's going to happen, to talk through it, to explain that in the end they'll feel better, to retain the connection afterwards, to support the patient in the aftermath, and to reinforce how strong and how brave they've been during it is so important.
I think also, you know, when you were talking about the mindfulness techniques, a big part of mindfulness is non-judgmental, having a non-judgmental stance towards what you're doing. And I think the more healthcare providers can develop those capacities, the more self-caring that happens. I'm a clinical psychologist. I actually work at Northwestern, and I'm the moderator for Schwartz Center Rounds, and I came to hear you give this lecture, but I'm just struck by all the interconnectedness between allowing ourselves to not judge what we're doing and allowing the self-compassion to come forward.
Yeah. You know what, something I'm really thinking about a lot is that somehow we have to create just a little bit of distance between ourselves and the patients in order to survive. And that distance isn't a fixed distance. It'll morph depending on what's going on. So to some extent, you do have to separate yourself and always keep in mind this sort of distinction between yourself and what's happening to the other person. That what's happening to the other person is not everything that's happening to you. But that awareness and that constant examination of where that distance is what I think is really important. Because it's easy for it in the crush of being a student or training. It's easy for that distance to just get to be a gulf. And then it's really hard to repair. So I think one of the key things is awareness, is to reflect, is to be aware of what's happening to you, either in the moment or afterwards. And with help, with coaches, with mentors, with respected faculty who can help you think about this stuff. There's lots of ways to do it. Schwartz Center Rounds is one way to do it. Some people use Balint groups, some people use narrative medicine, journaling. There's just a zillion ways to think about that.
The agenda you laid out was extremely rich and very broad. How do you do it at the Mass General with regard to the medical students?
Well, you know, Harvard Medical School is sort of it's an odd place because the places where students go are vast. I mean, there's lots and lots of training sites. So there's no one way that this is done. What we have is a uniform curriculum for the first and second years. Everybody does patient-doctor. And our patient-doctor, I don't know what you do here, but from the very first week of school, students are assigned to tutorial groups, and they go out to the peripheral hospitals, and they're small groups of 6, and they have faculty with a 2-to-1 ratio. So there's 1 faculty for 2 students in these 6, so 3 faculty to each tutorial group. And we go start to meet patients right from day 1 of school. And they get to interview patients on the wards or in clinic. And they go with a partner, fellow student, who watches and is a peer coach, and with a faculty member who can give them feedback. And those people are chosen to be models. And it's very much what you are developing here. So that's one thing. That's sort of uniform across sites. The third year, we're having a big change happen now because we're now having these longitudinal principal clinical experiences. So instead of people going to a surgical elective here and then a medicine elective there and then to Rhode Island for something else and blah, blah, students are now assigned to just one place to get all of their clinical experiences in the third year. And that establishes more consistent mentoring and more consistent educational integrity in a way at each site. And within those sites, people get to do whatever they want. So people are being creative and doing different things, depending on the richness of the faculty and the interests of the faculty at each site. So some people have built into that curriculum humanities, literature, narrative medicine, all kinds of different things, but it's really up to the individual sites. So no one uniform plan at our place anyway. Other questions?
So I was wondering, as we think about the age of innovation that we're in right now, with new technologies like telehealth and telemedicine, is it possible to provide compassionate care when using these new sort of technologies and new applications for them?
It's a really good question. I don't know. I mean, I've not used that kind of stuff before, but when I think about, excuse me, just wreck your tape. When I think about even talking over the telephone, synchronous communication to a patient, very often, I won't know what the patient wants when I start that phone call, and you have to sort of work your way through it, and eventually you get to understand what it is the patient's asking you about, and you come up with a solution. You couldn't have known at the beginning what it was you were going to do or say, right? So there's space with synchronous communication devices to have that kind of interaction. And that can certainly be compassionate because the tone of your voice comes through even if you can't see the person necessarily. I mean, this adds a whole other dimension. But the idea of telehealth and the ICU movement with telehealth, I have no idea how that all's going to work out. I don't have any knowledge of it. It's a good question though. Be good for study.
I know you mentioned a little bit about how sometimes physicians or healthcare providers have to redirect a conversation and how that's perceived as sort of being cut off and like the patient's needs aren't being understood well. So recently we had a resident experience where some of the first-year medical students went to the hospital, and me and my partner encountered a patient who was trying to share information that was not relevant, and it was something where it kind of went on for maybe a period of 20 to 30 minutes. Mm-hmm. And later on we realized that, this is something that we would need to figure out how to mitigate. How do you know when to redirect and when that's detrimental?
So in the first year of medical school, and probably in the second year too, everything is important. Because it takes clinical experience to know what's important and what's not important. Because you don't have yet the framing or the diagnostic infrastructure to know where to place certain concerns or symptoms, right? So in the first year, it's okay to do that, to travel with a patient and just to see what comes out. That's your only chance you're going to get to do that. So go for it. Don't worry about it. Okay, so then you get to the real world and you really have to figure out how to make use of your time, right, in a different way. And I think if you've really decided that time is short, you have another patient waiting, and this is something that is interesting but may not be crucial, then what do you say? What are you going to do? What have you done to transition the conversation? Anybody had that experience? No? All right, just play it out with me. What would you do? What could you say? That would be an okay transition in the conversation. It's tough, huh? Thoughts? You're gonna get ready to hand that microphone over. Takers? Go ahead.
You could redirect the conversation back to sort of the line of questioning that you had by asking them to sort of re-clarify something that was mentioned earlier, so as to not necessarily interrupt them, but ask for sort of their help in sort of really nailing down what they were talking about.
Okay. Behind you.
You could thank them for what they told you and say, this is clearly something that's really important to you. And if, for instance, you're in the hospital, you say, I'd love to come back to you and talk to you this later. There are a lot of things that, like, I guess you can like say, like, my time and your time are both really valuable, and then you can kind of transition back into the narrative, but by just acknowledging the fact that even if we went off course, it was still important, that acknowledgement might be, I think that is compassionate.
Absolutely. So here, I just want to tell you a little tip. Talking about what you might say is really different from spilling it out and saying it out loud. So if you're having something you're having trouble with, try practicing saying it out loud. Because just thinking about it and thinking about what you might say never translates in what you're going to say. You'll be stumbling and bumbling. It just happens. It just happens. It's like kind of, you know, it's like you wouldn't be expected to go in and put in a central line without practicing it a million times under supervision. We need to practice these. They're psychomotor skills. These communication skills are psychomotor skills. They're just like learning and putting in an IV or something like that. You have to practice to get really good at it, and that means you have to say the words out loud. You can't think about it. You can't say what you're going to say. You have to actually do it. So the idea that I hear this is important to you, and I really would like to hear more. Right now, I need to just ask you a couple of more questions so I can be sure I'm not going to miss anything when I'm thinking about how to treat you. So if you don't mind, let's put that aside for a little bit. Never promise if you're not really going to come back, though. That's another thing that's really important. Other questions? Yeah?
Especially when we were considering, you know, we had these other discussions regarding detachment and concern, or balancing one's own compassion with the need to get a certain procedure done.
Yeah.
Yeah. In a way, detach yourself from that situation. So I guess we were wondering, are you aware of any studies that maybe look at evaluating physician compassion on a more humanistic, or you know, whether like evaluating a physician's ability to show empathy or compassion in regards to like a loss of a family member or something like that, rather than like such a procedural study?
I just showed that because I think it was really interesting, and I think, you know, DeSetti. I know he's out of town. I kind of hope to meet him.
He expressed his regrets. He couldn't be here. He's in Australia.
Yeah. Okay. Well, that would be a problem. I just think it's interesting because it's just a physiological fact that is what is happening. It's not whether it's good or bad. It's, okay, if this is happening, then what does this mean? And is there a tipping point? Is there a tipping point where that kind of downregulation preserves our ability to act, to intubate somebody, to put in that line, to do all those things in the ICU and every day on the wards? Is there? We have to do that. We can't just be upset every single time we have to do something to somebody, right? We won't survive. But is there a tipping point? I think this is a really important research point. Is there a tipping point beyond which we just stop feeling things? I don't know the answer to that. I don't think anyone does. But I think that that's why this notion of being aware of the distance that we are creating is so, so, so important. But to answer your other question, there's a lot of research on the impact of different types of communication on satisfaction, malpractice, adherence to medication and treatments and recommendations, and on particular clinical outcomes. There's much less on empathy and compassion and outcomes. And I think it's because it's been very hard to define, it's been very hard to operationalize. But I think the research is starting now. So should I stop? I don't want to keep everybody forever. I enjoyed it so much. Thank you so much.